Hello and welcome. I'm Dr. Marlene Maheu, and I'm here today to talk about primary care telehealth interventions with our special guest, Dr. Shereen Nabhani-Gebara. Welcome, Dr. Gebara.
Thank you. Lovely to be here.
I'm the executive director of the Behavioral Health Institute located at Telehealth.org. I'm the founder of the Journal for Technology and Behavioral Science, and Dr. Gebara is the associate professor of pharmacy at Kingston University in London. She's an expert in technology-enabled care and the principal investigator for UK and European-funded technology programs in telehealth. She's a consultant for healthcare organizations and their implementation of telehealth. Today, we're going to be giving you material to help you define and compare different terms used to describe the use of technology in healthcare. Many times these terms are used loosely and they can be confusing. We'll be showing you how to actually conduct telehealth sessions using different types of technology. And so you should be able to discuss the key steps of a technology needs assessment for using technology in the management of COPD in primary care and specialty care. We'll help you identify the technology features to request from vendors to match your needs. We'll be talking about implementation so that you will be able to outline your implementation strategy and your staff roles for using technology in your practice. So let's start with the question, why telehealth?
Well, it's a very simple answer. We can do so much more with telehealth. We can take better care of our patients. We can streamline services at a better rate. We can offer more flexibility. Bottom line, we can do a lot more with telehealth.
And if we dig down a little bit more about telehealth at home, let's discuss that.
Looking at specific examples as to how we can provide this virtual support with telehealth. The main goal is to be able to provide care between clinic visits, to bridge the care between clinic visits when the patient is at home and away from our direct supervision. We can also use it to provide counseling and education, which can then empower the patient and encourage them to take better care of themselves. Studies have shown that it can improve health efficacy. We can also use it to provide health coaching. So, for example, to lose weight, quit smoking, we can provide that health coaching remotely, which also provides that flexibility and makes it more streamlined as a service for the patient. Another very important element that telehealth can provide for us is when the patient is at home, is feeling poorly and unsure whether they need to seek help or not. Telehealth can provide remote monitoring that can then provide the best evidence as to whether the patients need to be seen or need to be taken to hospital or they're safe to stay at home.
As for virtual care at home, we see that the information that a patient is able to give us in a session is often so limited and not always accurate. They may think of something, then they forget once they're in the session. But when we allow them to have tools to communicate digitally, they can sit and maybe have family members included, type a more thorough reflection of what's really going on. Are you seeing that in your work too?
Yes, indeed. Some of the tools that we can use, for example, we can design specific questionnaires that we can ask the patients to fill in between clinic visits. Then we can guide their feedback and we can ask about mood, we can ask about activity, we can ask about exercise tolerance so that they can provide that feedback between clinic visits.
It could be on somebody's smartphone, and it's not that many questions. You can't ask them 50 questions, but 5, 10, quite manageable with a phone these days. The other thing is the involvement of an interprofessional team. When things are delivered digitally, then we can have other people in the office assigned to attending to different aspects. Are you seeing that in your world as well?
Certainly, with digital platforms that are specifically designed to allow multiple users to have access to the patient hubs. With a digital platform, multiple healthcare professionals can monitor, can intervene if they see something that is out of range. That can be done remotely, and it can be done asynchronously as well. So the patient inputs their data, but then when the healthcare professional has time to look into the patient hub to see how the patient's doing, what their respiratory status is, what their vital signs are doing. So it really offers that flexibility and really promotes interprofessional collaboration.
One thing I also should mention is that you are based in London, so you are in the British system, which is more advanced than the US system in many ways. Great Britain is a single payer system. The government years ago said, we are doing this, and the entire country did it. In the US, there are 50 states to deal with 50 state regulations, all the federal regulations, and it's complex. So that's why I'm always delighted to invite you to these trainings, Dr. Gebara. There are some differences that you may be talking about. If they don't see it right now, they will.
Yes, but we have the same challenges in implementation and uptakes. The lessons are the same and the experiences are the same.
So let's talk a little bit about some of these other functions of the platforms and what they can allow.
Telehealth can improve adherence. We know from lots of studies that adherence could be as low as 15 to 20%. Of course, some patients are very adherent. They rarely skip a dose, but you do have people who either intentionally or non-intentionally do not adhere to the treatment protocol. With telehealth, with the use of technology, you are able to send messages to remind patients, to emphasize the importance of adherence. So it's not just as a reminder, it's to confirm that if somebody adheres to the treatment, this is how much better their quality of life will be. So it's not just telling them don't forget to take your tablet, but it's also saying studies have shown that those who are 80% adherent to their treatment have this much quality of life or this much improvement in their conditions. It's direct and indirect reminders. It's a way to provide proactive care with the ability to monitor patients remotely. You are able then to detect deteriorations early on. So instead of waiting for the deterioration to become so unbearable that the patient calls the ambulance or needs hospitalization, if you're able to intervene early on and provide treatment within the safety of the house where applicable, then you are preventing hospitalization, you are reducing healthcare costs, and you are improving the quality of life for your patient, because patients hate to be away from home.
Let's talk about the terminology.
Historically, the word electronic health or e-health was the umbrella term that encompassed all these terminologies.
In the United States, the derivation of these terms is a little bit different. It started with telemedicine, then it moved to telehealth, and e-health took hold in Europe at about the same time. At this point, most of the laws are being written with the telehealth word because the laws are getting written with those words in it, which is really nice because it is more inclusive of this interprofessional team as opposed to telemedicine excluded some of the providers that are quite instrumental in delivering care.
Telehealth includes telemedicine, telemonitoring, and telecare. I want to touch upon mobile health. Before smartphones, maybe 15, 20 years ago, telehealth video were responsible for transmitting the readings and receiving instructions from the healthcare professional servers. However, when smartphones and smart tablets came about, then we no longer need that kit as a sender. So that's where the term mobile health came about. The smartphone became a hub for transmitting and receiving communication. Using telehealth, we are able to collect patient information, vital signs, symptoms through the smartphone, and then transmit that wirelessly through the mobile network into the healthcare professional server. Decision support systems can then identify readings that are out of range and generate alerts, and these can then be triaged by staff that will escalate to the attention of the primary care physician, perhaps, who will then be responsible for confirming and intervening early. This is how the process works.
These data input channels are not designed to dump a load of information in your lap and force you to deal with it. The ones that are more highly evolved only give you the anomalies. So let's say patient was doing really well. You don't need to get that day-to-day information. But if something happens and all of a sudden they're spiking up, you may want to be alerted to that.
True. The alerts can be customized to your practice. There are acceptable normal ranges, for example, but maybe in your practice you want to be more conservative and maybe you want to be alerted if somebody is on the higher range of normal, for example. Decision support systems can be adjusted to your practice so that the alerts are generated per your comfort level.
We're going to dig in a little bit deeper on definitions. Let's start with telehealth.
Telehealth allows the remote exchange of data between a patient and their healthcare professional to assist in the diagnosis and management of disease conditions. This is a big term, and once we break it down, you see that there are other more specific terms that we will be using today in this session. Telemedicine allows the remote treatment and management of patients. So examples of that would be teleconsultations, also better known as virtual consultations. It could be telepharmacy, it could be teledermatology. So depending on what the consultation is about, the terminology would reflect that. So this is where you would collect the patient's symptoms or provide the management protocol. It will be during that session. Telecare is allowing the remote monitor of an individual's well-being and environment. So this is when we talk about sensors around the house, smart homes, or sensors that detect falls or leaks or floods. So all of these sensors can be embedded into a patient's environment to allow them to live safely and independently at home. And that's what we refer to as telecare. So it's nothing to do with their health or disease, it's their well-being and living safely and independently at home. Telemonitoring allows us to remotely monitor patients, again, who are not in the same location as the healthcare provider. This comes in very helpful. So we have a variety of peripheral devices that are Bluetooth enabled and that are able to connect with the smart device that will then be responsible to transfer the reading to the healthcare professional server. Examples would be wearables that have sensors that can measure lung function or heart function, spirometers or pulse oximeters, electronic monitors that can monitor inhaler technique and adherence. So all of these are available as Bluetooth enabled so that when the patient does the reading at home, is automatically transmitted to the healthcare professional. And finally, as we discussed the advent of smartphones, we now use the tablets and the smartphones as transmitter. We no longer need a standalone kit that does that job. We are using our mobile phones to receive care from our healthcare provider.
Let's talk about the specific uses of technology that's recommended for patients living with COPD.
Guidelines were issued in the past year by the VA and Department of Defense clinical practice guidelines, and they essentially describe critical decision points in the management of COPD and provides that clear and comprehensive evidence-based recommendation. You might wonder, is the use of telehealth recommended? Is it evidence-based? If we look at recommendation number 19, you can see that these guidelines do suggest offering telehealth support that includes telemonitoring and using health apps as well as part of the patient care. And within it, they describe that the use of telehealth provides benefits that would increase access to care. Telemonitoring will reduce healthcare utilization because it can prevent hospital admission. The use of teleconsultations and virtual consultations are very flexible for the patients, especially patients who can't come alone to a consultation. They need a family member or mobility is a problem. What we call telepresence is to support patients, to provide them with the health coaching that they need. If you are recommending, let's say, weight loss or exercise or specific nutritional intervention, having that health coaching session virtually is quite inclusive.
One of the things I want to mention about this health coaching is that some offices may not have a health coach on staff. There are some states that have reimbursement for health coaches. I know Illinois in particular has a fair amount of reimbursement that's available for health coaches, part of Medicaid. It may be worth having a billing agent or billing service look into this because it might be worthwhile. The other part that I want to mention is there have been decades worth of research showing what types of messages can be sent through a digital device. People don't like typos and threats. They don't like pictures of black lungs, for example. And I think most clinicians are aware of that. But when we engage a vendor, we need to educate them about what our population needs. It falls on us to be aware of the fact that there's literature. For example, in the text messaging encouragements, people like to have uplifting message, not threatening. These things have been shown to make a tremendous difference. There's an entire body of literature to tap into. So let's shift now and talk about some specific patients. We're going to be encouraging you to think about using different types of technologies with different patients and different symptom patterns. Let's talk about Carlos, our patient number one.
Carlos is a 60-year-old man living with COPD. He called the practice because his chronic cough had worsened over the past 7 days. He is not short of breath, but he described his cough as productive and is now interfering with sleep. He lives alone. His son checks on him several times per week on his way back from work, but he can't spontaneously arrange a visit to the practice on short notice. In this case, Carlos can't come to the practice to be assessed. Can virtual consultations be useful for him? Virtual consultations are between a patient and a healthcare professional. It allows or it facilitates clinical assessment, advice, treatment planning, either via video or via telephone.
I also want to mention here that recent studies looked at which is used most often, the video or the telephone. The telephone by far has been used most frequently, and now Medicare reimbursement for behavioral conditions has approved telephone and video indefinitely. Those of you who may need something coded as a behavioral issue having to do with adherence, for example, you could talk to your billing staff about reimbursement.
When we talk about virtual consultations, there are lots of questions. Are they as effective? Can we deliver person-centered consultation virtually? Is that really possible? What are the benefits and risks of using virtual consultation for the patient? Considering the patient, the disease, and the state of the disease is extremely important. Determining the patient's suitability, do they have access to technology? So this is where we talk about really health equity and being inclusive in our care. Is their environment suitable? So we talk about safeguarding. So do they feel safe talking about their health condition at home? Do they have their own space? There might be some language barriers. Do you have access or do they have access to somebody that can translate? There could be a sensory impairment, so maybe the patient's hard of hearing. Can they lip read? So all of these things need to be considered ahead of time. So whilst virtual consultations are something that can be quite flexible and streamline care, they need to be planned if you want to do them properly. For some patients living with frailty, maybe a home consultation is more suitable for them. A lot of complex issues that need to be considered. Talk about patient choice as well. Some patients may be quite happy to have a virtual consultation. Other patients might feel a bit slighted because they might believe that virtual consultation is not the same as face-to-face and they're being shortchanged. I know in England, there was a huge outcry when the primary care physicians, who we call general practitioners, went to virtual consultations. And suddenly, you have these inflammatory headlines saying GPs refuse to see patients. It's important to see how the patients view virtual consultations so that they understand that they're not being shortchanged or being ignored. Ultimately, if you want to consider all of these things, it might be suitable to develop your own triage system, like a tick box exercise to come to the decision whether your patient with their disease state is suitable for virtual consultations or not. It's extremely important, again, before jumping in, is to consider the technology set up at the practice. We will talk about this a little bit later, but considering whether do you have the space for it and the equipment, do you have a reliable camera, reliable microphone, All of this is very important. And if something fails, is there somebody reliable that you can call that can quickly support? Because if you're in the middle of a virtual consultation with a patient and something freezes, so there needs to be support available. Some of the studies that we've done looked at the healthcare professional experience with virtual consultations. And even though healthcare professionals loved the flexibility of virtual consultations, one of the biggest barriers was the fact that they did not have proper technical support. That is something that needs to be considered seriously. In terms of reflecting on the patient's needs during any consultation, it's mnemonic that can be referred to. So, for example, P for personal, understanding what the patient likes to be referred to, what is their nickname, what are their preferred pronouns, a non-binary patient, asking them what's important to them, providing empathy, tuning in to what's important to them and whether they have a solution in mind, and to be able to offer the support that is needed. Going back to the basic technology issues that I mentioned before, it's extremely important for specifically the staff using the technology and conducting the virtual consultations that they have the appropriate technology, reliable connection, reliable Wi-Fi, appropriate camera and headset, technology support in case something does go wrong. Spending some time developing the appropriate communication skills that are relevant for virtual consultations, data protection, confidentiality, and consent. For example, there are some patients maybe who don't have their own Wi-Fi at home or maybe prefer not to connect from home and then would use a public Wi-Fi. Now that's not secure, obviously. So there are some platforms used for virtual consultations that provide security. So whether patients are logging in from a public Wi-Fi or their home, it doesn't matter because your platform provides that security. So these are things that need to be considered. So going back to Carlos, a virtual consultation is scheduled. So he has done these in the past with the praxis. Carlos's son was able to join from work, and a virtual examination was conducted with a healthcare professional. The patient, so Carlos, appeared comfortable. Their respiratory rate was 24 breaths per minute, not using accessory muscles. And so the decision was for Carlos to start prednisone 40 milligrams daily for 5 days.
Let's talk about the virtual assessment now of acute COPD.
In this case, you can see that Carlos was having a symptom. It was a change from his baseline, and virtual assessment is needed. Even though there is no clear guidance on the assessment of acute exacerbation of COPD through virtual visits, however, there are some suggestions of how that can be done with the use of technology. The table that I'm going to discuss was published in a recent article in the Cleveland Clinic of Journal of Medicine, which they adapted from the International Gold Guidelines. They suggested 3 elements to provide the interpretation of whether the patient needs to be brought in, whether the patient needs intervention or continuous monitoring. A suggested assessment that can be done via a virtual consultation would be to count the respiratory rate. The rate above 30 breaths per minute indicates increased work of breathing. And then through the virtual consultation, you can assess mentation and also look for tremors. A change in mentation could be a sign of a more severe situation. And the presence of tremors could suggest that there's ongoing acute respiratory failure. It may not be possible, but to visualize whether the patient is using their accessory muscles, so you can ask them to lift their shirt. If that is observed, the interpretation would be an increased accessory muscle activity indicates ongoing respiratory distress. Even though the patient's not with you in the clinic, they are virtual, you are able to make this interpretation and make a clinical judgment based on that to either escalate, provide intervention, or continue monitoring.
Thank you. Let's talk about patient number 2. That would be Tom.
So Tom is 77 years old, lives with advanced COPD, also has heart failure and depression. He's had a history of 3 hospitalizations in the past year, and each one has a length of stay exceeding 7 days. And due to multiple hospitalizations, he has moved in with his daughter, Sally, who is his caregiver. During the consultation with the primary care physician, Tom indicates that What's really important to him is that he needs to stay out of hospital and asks his doctor, what can we do to keep me out of hospital? My hospital stays are long and uncomfortable and lonely. And Sally, his daughter, adds as well that whenever her dad has these exacerbations, she's scared. She doesn't know when to seek help because whenever she asks her dad, he always says, oh, I'm fine. So there's that judgment call that is very uncertain. Dr. Jones suggests telemonitoring as an intervention that can help achieve what Tom is interested in. With telemonitoring, you can use a variety of independent, or what we also call peripheral devices that are Bluetooth enabled. These can help you measure a variety of vital signs. So, for example, a pulse oximeter can provide your patient's oxygen saturation. Thermometer would provide you with an idea whether your patient has an infection. In case of Tom, who has heart failure, it will also indicate how controlled his heart failure is. And using questionnaires, you can also monitor your patient's mood and administer simple tools like the COPD assessment tool, which takes 2 to 3 minutes to complete. With all of these, you are able to have a holistic view of what is going on with Tom on a day-to-day basis. And this is how it works. We've got all these peripheral devices. Because they're Bluetooth enabled, they can connect with the smartphone, and then the smartphone can then send these readings wirelessly to the healthcare professional. So the patient, in the safety of his home, would be doing all these measurements using all these devices that we talked about, and all of these measurements would be transmitted securely to the healthcare professional server, the triage center. And this is where these readings are processed via decision support system algorithms that will then generate alerts. If any of the readings are out of range, then these could be escalated to the attention of the healthcare professional, who can then choose to intervene if suitable. The measurements or the patient data that is being sent from the patient's home to the healthcare professional server, all an encrypted transmission and secure. This is telemonitoring. This is what we discussed before. It can include the peripheral devices that we talked about. It can also include the more advanced devices such as wearables. There are some vests that have embedded sensors in them that can monitor lung function or heart function. You also have smartwatches. These are considered wearables because the patient wears them all the time, and that can also give you an indication of the patient's activity. Some smartwatches also will give you an ECG reading as well. So technology is evolving all the time, and we can do so much with it to enable us to monitor the patient while they're at home. In another study, they did not use anything fancy. All they used was a pulse oximeter, which, thanks to COVID, a lot of households now have it. What they did was ask patients to use the pulse oximeter and monitor respiratory rates on a daily basis. They did that with 110 patients for 12 months. And that generated 27,000 recordings, which means the patients were actually adhering up to, on average, around 5 times a week. But what's very interesting about that study is that they were able to detect 360 exacerbations just from the use of a pulse oximeter. So sometimes you don't have to use expensive pieces of kit to be able to monitor patients. You can use readily available devices, and they can still give you an idea of what's going on with the patient while they're not with you. Now, if you are going to provide that service to your patients, taking the time to educate patients is extremely important, because studies have shown that some patients are technology skeptic. However, these studies did show that if you take the time to show them how it works and what are the benefits, these patients will be your biggest champions. That step is extremely important, because if not done correctly, the patient will not take the readings at home, and then you're back to square one. So it is time consuming, but it is extremely important. That means you need to dedicate trained staff to do detailed training. You need to provide teaching materials, so leaflets with lots of pictures, big font, simple language, and also allow time for Tom to think about it and make a decision. Some people may not be up for that because some people might consider having continuous monitoring an intrusion on their health. They don't want to be reminded that they're ill. So it can be a very personal decision. The majority of patients will be on board and will be interested in this intervention, but you have to take the time to have that discussion. And then, if possible, a home visit would be extremely valuable, not necessarily a healthcare professional, but certainly a dedicated member of staff who's trained can go and check if it's a supportive environment, if the internet is reliable, check on the technology setup, make sure that the patient and their family understand what to do, understand the steps. And again, that could be time consuming and it could be adapted. Again, it doesn't have to include a home visit, but for some patients, perhaps it might be helpful to do that because there is an upfront cost with it. If your patient is not suitable, you need to realize that from the beginning, otherwise it will waste your time. When it comes to implementation, you need to provide the patient with a schedule so that they know exactly how they're using it and when they're using it. That way they can integrate it into their routine. In Tom's case, for example, they wake up in the morning, they weigh themselves. After they use the inhaler, they can use the pulse oximeter, take their temperature. And in the evening, you can ask them to complete a mood questionnaire or a COPD assessment tool questionnaire, and then maybe repeat the pulse oximeter. This is very flexible. This is based on the clinician's judgment and what is needed to assess the patient. All these readings that are being generated by the patient on a day-to-day basis, of course, these will not be viewed by a member of staff. There are clinical decision support systems that are algorithms that will look at all the readings and then identify those that are out of range. And only these will generate an alert that will come to the attention of a dedicated member of staff who will then have a look at it, make sure it's not a false positive, perhaps call the patient and escalate where necessary. So again, training a dedicated member of staff is extremely important. The other end of the spectrum is, other than alerts, this will also allow you to check on the patient's disease state between clinic visits. So on a weekly basis, maybe, healthcare professional at a glance can see the patient's progressions. These platforms can generate visual graphs so that you don't have to look at individual readings. At a glance, you can quickly see whether there's been fluctuations. So Tom was educated, he was given a schedule, and 6 months later, Tom has not been hospitalized and his daughter rests easy. She's happy to leave her father because she knows that he has virtual monitoring taking place. His care shifted from a reactive to a proactive, more preventive model, thus preventing hospitalizations through early identification of exacerbations.
Let's talk about patient number 3.
Jacinta, 68 years old, again, advanced COPD. She lives with diabetes and hypertension as well. And her clinician noticed that she has a suboptimal response to her inhaler therapy, which has caused several exacerbations, which meant she needed antibiotics and steroids. This is where we can talk about a different type of technology, which is the electronic inhaler monitors. They record not only whether the patient's using the inhaler, but can also record how the patient's using the inhaler. So inhalers can be quite tricky for some patients, even though patients might start off using them correctly. 4 or 5 months down the line, their inhaler technique drifts and they're not getting the optimal dose that they should. Usually, re-emphasizing appropriate inhaler tech needs to be repeated a couple of times a year for some patients. And for those where you have doubts that they're not using their inhaler correctly or they're not using it at all, using an electronic inhaler monitor would give you that insight into what's happening. There's a variety of features out there. Some of them are synchronous, so in real time, they will give you that feedback. Others will store the data in the device, and then that can be forwarded on to the healthcare professional. It's a good idea to have a look at what's out there, but certainly they are quite useful. Studies have supported their impact on inhaler use technique. And if you come across a patient who is not adherent, that would be a good opportunity to refer them to the pharmacist who can look at the inhaler technique and drug interactions. This is where that interprofessional collaboration can really help provide a holistic approach to patient care.
Behavioral health professionals are often included in primary care settings now, and so their role can be supportive as well as educational in a lot of cases. Psychologists and social workers are paid by Medicare for behavioral issues. Reimbursement for marriage and family therapists and counselors are included. So this is new.
Yes, indeed. Going back to Jacinta, with the help of the electronic inhaler monitor, it was noted that she was not using the inhaler correctly, which means she did not need therapy escalation, but she did need an in-person session whereby she was shown how to use the inhaler again. She was provided with a video demo as well, and then a plan for this to be reinforced twice a year to make sure that she continues to use her inhaler correctly. Whenever Jacinta has an exacerbation and she needs steroids, it is important to consider how will that affect her blood sugar control and her blood pressure control. We know that steroids can increase both of these, so they can cause hyperglycemia and hypertension. So again here, an opportunity for telemonitoring and to see whether these steroids are affecting the blood sugar control. Does the patient need a titration of the antidiabetic medicines during that pulse treatment? And that can be done remotely. So the patient does not have to come in for these readings.
Thank you. So now we'll shift to patient number 4, Tyrone.
Tyrone is a 55-year-old patient, again living with COPD. He is stable on his medicines, but has exercise limitations. He is obese and smokes half a pack a day. He lives at home, but his daughter lives close by with her family. So this is where we want to talk about pulmonary rehabilitation as an effective option. It's a multidisciplinary program that has been shown to have a very positive impact on patient outcomes living with COPD. It has been shown to improve quality of life and exercise capacity. 6 years ago, the American Thoracic Society, in a joint statement with the European Respiratory Society, indicated that the increased implementation and delivery of pulmonary rehabilitation should be integrated into a patient's care. Now, the good news is that we can deliver pulmonary rehabilitation virtually. In this study, what they did was they compared whether home-based virtual sessions for pulmonary rehabilitation compare to outpatient pulmonary rehabilitation where the patient came into the clinic. And the study showed that they were quite similar, but flexible for both the patient and the healthcare professionals. With these sessions, you can provide education, support for all the interventions that are needed. You can also provide synchronous virtual exercise supervision. So, for example, if exercise is one of the interventions, to see how the patient is implementing their exercise protocol. So all of this can be done virtually, and the studies have shown that it is possible and effective to conduct virtually. If you need a respiratory therapist or a physical therapist, that person can deliver these sessions remotely to a group of patients, all gathered in one place, maybe in a health center or in your clinic, or it could be one-on-one at home. Even though you don't have somebody locally, you can use that hub and spoke model to allow resources to be delivered to your patients. We did talk about digital health coaching as quite valuable because it allows you to reach the patients even when they're at home, to motivate them and engage them to make the changes that are needed in their lifestyle. So it could be a virtual consultation one-on-one, or it could be a phone call, or it could be a text message. You can use a hybrid approach for delivering digital health coaching. And certainly in the future, we probably will all have robots in our homes telling us what to do and what not to do. So going back to Tyrone, a personalized pulmonary rehab program was designed for him that included an exercise routine, a smoking cessation program, and a nutritional assessment for him. Through his tablet, he will receive daily tasks that he has to complete, challenges with some automated and semi-automated messages. He has weekly virtual consultations. His progress is monitored remotely, so he doesn't need to come in to be weighed or to be checked. Wearable devices like an activity monitor or smartwatch that can indicate his level of activity, the weight scale to show progress for his weight loss, and similar interventions.
Thank you. Let's shift to talking about telehealth implementation.
A lot of people get really excited and say, right, I'm going to go and I'm going to implement telehealth. And they think that they can just simply parachute an intervention straight into their practice. However, that doesn't work. And I've seen it not work with a lot of waste of resources and time and frustration. So it's always good to take that extra time and take a step back and really check what your practice needs. The first step is a needs assessment. So what does your practice need? Which population of patients will benefit most from a telehealth intervention? Not all of your patients living with COPD are going to need this. So you need to have specific criteria, for example. Maybe your patients that have multiple hospitalizations, these are the ones that will benefit. That assessment is extremely important because each practice is different and you cannot allow the vendor to tell you what you need. It's important to take that step back and involve the stakeholders. So involve your staff, involve the patients and their caregivers, and understand how technology can support your practice. Once you have that assessment, then you can go to the vendor and say, right, I want a telemonitoring for this and that. So you'll have a list of features that are guided by your needs, not guided by their agenda. I cannot emphasize enough how important it is to take that time to do that. And then once you have that meeting with the vendor, it's also important to understand what are they offering you. It's not just enough to have a list of features that are part of your package. It's also important to see whether they can offer you triage as part of the service. Are they going to be offering the equipment? Will they support the training for the staff? Will they support the training of the patient? You have to think about reimbursements, of course. But all of these need to be considered to make sure you choose the right company and the right package that works for you. And then let's say you've shortlisted 2 different packages. This is where you bring in your digital champions, the staff and the patients and caregivers, and let them have a look. Let them have a play with the system, not in real time. So don't deploy it yet. Let them look at it. Is it user friendly, or is there too many clicks to do a very simple step? So these are all things that your digital champions can help you with. Because at a glance, you may not be able to see the things that they see. So it's important to have them involved in the process. And then once you've chosen your package, then training is extremely important for the staff, for the patients, for the caregivers. There's a very useful website by the Department of Health and Human Services for telehealth. There's a section on patient education that you can use. There's a section as well for staff, so staff involved in providing the digital service. They need to be trained, they need to be supported as well. So there's a section on what they call telementoring. This will be part of the bibliography. And then you need to develop a workflow protocol. How will it work? Who's responsible? Which patients are going to be recruited on it? How will it be done? So all of this takes time, but it's extremely important to make sure that you implement something that is sustainable and won't crash by the end of the month. And when you do come to deploy, make sure that you pilot this on a small group. You have eligibility criteria, which patients are going to be offered this service, because for some stable patients, it'll be waste of resource. For the overly complicated, complex patients, maybe they are not very digitally literate. Again, it's not suitable for them because they won't know how to use the system correctly. They'll generate a lot of false positives and they can waste a lot of staff time. So getting it right and having the inclusion criteria right is very important. Developing a workflow so that the patient is informed and educated. Patient is given all the documents that they need to make an educated decision. Where possible, have that staff visits to the patient's home just to double check suitability of the environment. You don't want to waste resources and you don't want to waste your staff's time. For all the staff that are doing all these extra responsibilities, you need to think if their timetable allow these extra duties. Are they interested? So maybe there might be volunteers who want to take the extra tasks because technology is an interest of theirs, and perhaps amend their job titles. That is something that can go on their CV, and that could be a transferable skill that they can take with them. And it's important to have a list of who does what and when. Some people don't do it, and that's where they fall into the trap of implementing something too quickly. I remember I consulted on a project and they weren't sure why they weren't able to get the benefits that they thought they will get for their patient population. And it was because the implementation was faulty. The staff were overworked. They did not have time to check eligibility of the patients or to train the patients. So it was several pitfalls, which meant that when they came to see the results at the end of 6 months, they were not impressed. They had only a handful of patients on the system and they were a bit deflated. Taking that step and spending that time up front is extremely important. And when you're ready to go live, roll it out on a small number of patients and evaluate it in real time. And this step will allow you to see whether the intervention that you chose was fit for purpose. It might give you further insight as to which patients may not benefit. So when you see something go live, you will have further insight. So that process that I talk about, it's an iterative approach. Even after you pilot on a small number of patients, you are provided with that extra insight in how it's going to work in real life. And that might lead you to a further need that you were not aware of. So you need to have an open mind that this process is continuous and you should be ready to adjust it where needed. Before going live, you need to think about this question: is the patient care pathway defined? Have you defined it specifically with which patients, which staff, at which point? Do you have the appropriate information technology infrastructure? And what happens if that fails? Do you have a plan in mind? Do you have a mitigation in mind? Have you set up your digital champions who can support and carry this project with you? What's the uptake like in terms of patients and staff? Do you feel a bit of resistance, and why? You have to know ahead of time that with telehealth, with any technology, there is an upfront cost, but then you will be rewarded long term after the system is live. And then finally, make sure that it's sustainable. And if you've considered all of these challenges, then you are on for a sustainable program. Tom is quite happy with his telemonitoring system. He uses his pulse oximeter, his thermometer. Yesterday, he woke up feeling a bit unwell, tight chest, short of breath. So his body feels a bit achy. So he measures his temperature, uses the pulse oximeter, and sends his reading. However, in the meantime, the practice server has failed and Tom's data wasn't seen. So now what? In this case, if this risk was not mitigated, then Tom's data will not be received or processed by the server, which means alerts will not be generated and the staff will not be informed of Tom's deteriorating state. So Tom is at home thinking that his measurements have been received, waiting for instructions. When he doesn't receive any calls from his practice, he thinks that his readings must be fine. And so he doesn't do anything. However, later on, his daughter comes in and finds him unresponsive, then he needs to go by ambulance to hospital. However, if the risk of the server failing was mitigated and planned for, when the server failed, an alert is sent to a dedicated staff That staff will then be responsible for contacting all telemonitoring patients to inform them not to use the system, and if they need any help, to just use the old-fashioned phone, and then to contact the IT department to resolve the issue. You need to have that mitigation in place because these things will happen. Tom was informed not to use the system, and when he feels unwell, he calls his healthcare professional and a home visit is arranged. So you can see the difference in these two outcomes is massively different. These platforms are capable to support multiple users, and they are capable to integrate into the practice's current electronic patient record so that you're not having to open two different programs. The last thing you want is to ask a clinician to log into a separate telemonitoring system to check on a patient. That's just a waste of time. What you want is a system that automatically integrates into the electronic patient records. When you click, you'll see automatically any alerts generated. Integration is extremely important. You really want any intervention to integrate into your existing electronic patient record system that you have. So that's another requirement that you can ask the vendor for, because one of the problems that we have is multiple systems. We have a system for blood tests or a system for imaging, a system for the notes. Healthcare professionals spend half of their time logging in. You want something that speaks to the existing system. And you want it as well, if possible, to reach out and include other healthcare professionals, as we discussed. If we've got specialists involved in the care of your patients, such as pulmonologists or endocrinologists, they should be able to, at a glance, check on the patient's well-being. As a conclusion, we've provided you with a whole host of ideas and technological interventions that can help your patients. One of the main themes that hopefully is coming through is that technology-enabled care, telehealth, is a developing field. It's becoming more integrated into patient care. It has the potential to transform healthcare delivery. Ultimately, it can improve patient outcomes and as well streamline the clinician workload to cope with the ever increasing demands.
Thank you so much for participating in this conversation. I appreciate your work.
Thank you so much for having me.
Next, I'd like to introduce our guest, Dr. Shawna Wright, to talk about the ECHO project. She's from the Kansas University Center for Telemedicine and Telehealth, and she is their Associate Director. Welcome, Dr. Wright.
Thank you for having me.
Would you please tell us about Project ECHO?
Project ECHO is a telementoring approach. It follows a traditional model of telehealth, where we have a hub and spoke model of education and mentoring, where we work to develop a community of practice. Currently, it's a global initiative, but it originated in New Mexico under the inspiration of Dr. Sanjeev Arora, who faced a battle in treating hepatitis C in the state. And he developed this model to increase access to care in rural areas of the state. And what he did is he adopted a video conferencing platform, and he joined with about 13 other providers to have an interactive form of learning that was heavily reliant on case-based discussion to enhance their competence and confidence in treating hepatitis C. That's the basics of Project ECHO.
Is Project ECHO the same as telehealth?
Project ECHO falls under that umbrella term of telehealth. And we look at the umbrella term of telehealth, we think about leveraging technology to improve healthcare. So that includes direct service delivery, which we might tag as telemedicine, telepsychology, teleoncology. But we also include anything that's related to education of healthcare providers or even public service announcements. Any way that we leverage technology to improve the health and well-being of people can fall under that umbrella term of telehealth. The difference that we see in terms of service delivery, where we have one provider using technology to directly serve or treat a patient, our contrasting ECHO model hopes to affect the lives of many patients by having our expert or our specialty team work with a group of learners and healthcare providers, and then enhance the treatment they provide to a wide variety of patients and consumers rather than that one-to-one approach.
Is Echo a webinar?
We prefer the word echo to webinar. And when we look at the webinar as a training model, oftentimes we can engage hundreds of people at the same time. Ideally, with the echo model, about 40 in attendance is pretty ideal. Once we're over that, the echo can sometimes fall apart. The echo model allows people to ask questions. Both our specialists and our participant learners can ask questions and interact with each other. We can see specialists and participating learners get advice from one another, exchange ideas, problem solve. So within that process, we're really developing a community of practice, which we very rarely see develop out of a webinar format of learning.
So what is the basic Echo model?
The basic Echo model is based on 4 foundational elements. It's the ABCDs of our Echo learning model. The A stands for amplification. And really what that is leveraging technology, using technology to expand access to scarce resources. But another foundational element of Project Echo is to share best practices. And when we do that, we reduce healthcare disparities because more providers are aware of our latest research, our best practices for any new treatment guidelines that have maybe been endorsed at one level or another. Another foundational element of Project Echo, the C, is case-based learning. And we know that we learn the most and we learn the best when we learn from each other. So when we have patient cases, real live patient cases, we learn more because we're interacting around those cases. And then the D in that foundation is web-based databases to monitor outcomes. There are many different ways that we look at that database. Individual institutions or organizations can develop web bases and metrics to determine how they're going to measure if they've moved their healthcare needle.
What is the mission of Project Echo?
The primary mission of Project Echo is to democratize medical knowledge, behavioral health knowledge, and get our best practice to underserved people all over the world. It really is a global initiative. So through Project Echo, our hopes are to expand the capacity of our workforces, expand access to both primary and specialty care for individuals, regardless of where they're living, to reinforce the idea of a multidisciplinary approach to healthcare, disseminating best practices, latest research, and any updated guidelines that we may have. And then, of course, to engage our partners in a continuous learning system. And at Project Echo, we refer to those as learning loops. And what we'll see in those learning loops is we have a specialty team, but when we pull those echoes together, we're pulling together other interprofessional teams, and they become engaged in an interactive learning process. So what we see through that is a co-management of cases, learning by experience, learning from direct didactic education, learning from each other, collaborating around clinical problems and using problem-solving skills to approach different clinical presentations, and then also having that comprehensive interprofessional advice that arises when we bring these groups together.
And the individual components of an Echo are what?
Well, a Project Echo has been around for a while, and all of the technology boosts we've seen through the public health emergency of COVID-19. The method is designed to leverage technology to bring people together. Our learning participants log in, they can use any computer, laptop, tablet, or phone. And we pull together a consistent group of providers. So once they're registered, we have our cohort, and they work with the same specialists. They meet regularly. They have interactive discussion over patient cases, and they build relationships. So I don't want to confuse the process. Echo is not a one-time consultation service. It's not a webinar. It's an interactive process. It's used to develop a community of practice and a peer support network to have that technology-mediated learning collaborative. So we're building relationships and interactions over patient cases rather than just beeping in for a consultation. It's a continuous learning model.
How many meetings would a topic cover?
How many separate sessions will we have
Right.
per topic? Well, that really does vary, again, depending on how the echo is designed. For instance, if I were to talk to you about the autism echo that is available in the state of Missouri, to my east, I would tell you they probably meet anywhere between 12 and 24 times in a year. And so they have an ongoing centers of excellence model, and they keep their cohort together, and they meet pretty regularly. Because funding is different in the state of Kansas, most of our echoes are briefer in the duration or the number of sessions. And so oftentimes our echoes will be what I call the most bang for your buck. We'll have anywhere between 4 to 6 sessions, but we'll really intensely try to collapse and disseminate the best and latest knowledge that we can to our rural providers. So it really does depend, Dr. Maheu, on the funding source and the design of the echo and how that's delivered.
Thank you. And the format, the typical format of an echo?
So the typical format of the echo is to welcome everyone in, do some brief introductions, and then we'll have a brief, hopefully no more than a 15-minute direct didactic training. And that's usually delivered by one of the specialists on the team. And following that didactic training, we'll dive into our case-based discussion. So one of our learning partners will bring a case that's maybe complex or difficult to manage. And after presenting that case, everyone who's connected, whether it's a specialist or a participating learner, everyone has access to ask clarifying questions, and everyone has the same commitment to making recommendations and problem solving around that case. So the case discussion really is the heart of an echo session. And then we wrap the session up by summarizing the case and the recommendations that the case presenter can take back to their practice and back to their patient.
Common echo outcomes?
Well, I think that as a healthcare provider, we want to focus in on patient outcomes. That's where we start. There's a variety of positive outcomes that we find from interacting with the Project Echo model. But for the patient, it's getting the right care at the right place at the right time. We see many benefits when patients are able to get the care they need in their home environments from providers that they know. But providers benefit as well. They're able to acquire new knowledge, treat more patients, refer fewer patients out, and still build a community of practice with their other learners in the echo formats. And that really says a lot about reducing professional isolation that we see sometimes in rural or underserved areas. The community in general can benefit from the echo model by reducing disparities for healthcare, retaining providers, and keeping their patients local. And when we do that, that healthcare dollar stays local, which benefits the community as well. And then when we look at the systems level, we see an increase to access, improved quality of care, and reduced overall cost in treatment as well. So there are a variety of positive outcomes from engagement and effective implementation of the Project Echo model.
Thank you so much, Dr. Wright.
I appreciate the opportunity. It was good to work with you today, Dr. Maheu.
In this next section of training, we'll be talking about different ways that we can be effective, and in particular to show empathy, feel empathy with the people that we're treating. Empathy, of course, is putting ourselves in the shoes of the patient or the family that we're dealing with. There's a tension between caring and kindness on one hand and remaining objective on the other hand. There's also a tension between getting emotionally involved on one hand and then responding to emotions and suffering on the other hand. So we've got to strike a balance in between all of that. And it's difficult when we're under time pressure. But it's particularly important in telehealth because video has been shown to diminish our viewers' experience of us by about 10%. We have to be aware of that diminishing effect of video and also try to amplify how we're going to have people get that experience of. This has been captured in some of the early literature related to telehealth with the term webside manner. That is the virtual equivalent of a clinician's bedside manner. There have been a litany of complaints by patients of their clinicians that involve a number of things. It's how they appear on camera, the fact that they might be checking their cell phones. The phone might be off camera, but it's clear that the clinician's looking at a phone. They may be chewing on a sandwich. They may be doing a variety of things that lets the patient know that they are not primary. Our goal, of course, is to give people the experience of our compassion and our wanting to help them. So we're going to go through 5 different steps that you might want to think about. The first is listen to clues that might signal the need for an empathic response, and that might involve something that you know you have to tell them about a diagnosis, medical diagnosis, a mental health diagnosis, something that you might suspect, things that would be difficult for any person to hear. Are you prescribing a protocol that would require a significant amount of time, focus, or pain? Can you offer some encouragement? Can you offer your staff's availability? Do you have tutorials that you may have created to offer them guidance? You may find some pre-recorded videos that will help do that for different types of procedures and medications. And you can consider thinking about a behavioral professional to offer additional support. The next issue would be to listen for what's not being said. Many times people are under pressure and they may not either know how to articulate their feelings or think that you're not interested. So they may have unexpressed emotions. They may be intimidated by you. Your education, your expertise may be something that they want, but at the same time, they're sort of afraid to be themselves around you. They might exhibit that by being too embarrassed or too anxious to remember questions. They may not ask things in a way that's methodical and easy for you to understand. They may actually be resentful of how poorly they've been treated by somebody else in the past or somebody in your practice. And they may not understand you. You may be using acronyms, you may be using terms or concepts that they are not understanding at all, and they're too embarrassed to ask about it. You may also want to listen for what's not being said by thinking about it from the perspective of your time. Do you truly not have time? And is there a behavioral professional on your staff that can assist? Is there a coach that might be available to help them? If you don't have one, you might want to think about hiring somebody who is a trained listener. There are many clinical psychologists, clinical social workers, counselors, marriage and family therapists who have training and could be quite helpful in a medical practice. The third issue is to stay present. On average, doctors listen to their patients for only 11 seconds at a clip. If you make it a practice to look your patient in the eye, to respond to questions with full sentences, and avoid looking around your room, that can go a long way. If you have to look around the room, if something's going on, you may want to take a second to just explain why you're being discourteous to them, because all they see is your face. They may not hear the sound coming from the next room or someone knocking on your door, trying to remind you that you need to move on to the next patient, but they do see your face. And if your eyes dart off, or if you're looking out the window and watching somebody walk by, they will notice that. People will be very much focused on your eyes and what your facial expressions are. If you do not have time, you can ask support staff to ask more detailed questions. There are many different types of digital tools that could send out surveys, polls, collect suggestions from your patients so that you can actually get feedback that could be useful to you. These things are particularly useful for people that are not compliant with your treatment protocols. They may not tell you in person, but they certainly would write it down if you gave them the chance. Did they have the opportunity to speak their mind? You may offer short videos, for example, to ask them to make topic lists so that when you come into the room, they will have the list ready. Many video conferencing platforms allow you to upload a PDF so that while your patient is waiting for you, they can be reading things like, please lock your door, please make sure nobody is within earshot if you don't want them to be, make a list of things you want to talk about, So they truly are ready for you. If you're not sure whether or not they're finished speaking, you could ask them, was there anything else? When you ask that extra question, you will get much more information than you might imagine. And then listen for stuttering or hesitations. You might offer them a kind word about breathing, relaxing, that you really do want to hear what they have to say. After difficult or emotional conversations that you've had, many professionals are taught to just push that aside because we have to think about the next patient. But emotional indigestion is very real. Things will come back up for you, and your mind, your psyche will bring it back up for you if it's not completed. So something will haunt you. This might lead to questions about what could you have done better. You might want to make some notes about issues to ask the next time. That is the conclusion of our micro lesson about empathy. We're going to shift to a basic overview of best practices for telehealth. The first issue is that of appropriate technology. And as we discussed in our last segment with Dr. Gebara, there are a number of technologies that are appropriate for COPD, including assessment tools. Another issue is that of data protection and confidentiality. In the United States, HIPAA compliance is the minimum what's required, and some states have laws that supersede HIPAA. You have to be compliant, whether they come from the federal level or the state level. In this next segment, we'll be talking about requirements and consent, look at a few other types of technologies and resources. So regarding the issue of practicing over state lines, all licensed professionals in the United States, except for military employees, are subject to the rules of each licensing board with which they're licensed. You might be licensed in 4 states, and you have to be compliant with all 4 states. This particular issue is also important if you think about your patient being in a different state, because with telehealth, the law follows the patient. It's very much like traffic laws. If you have an accident in a foreign state, it's not the law of your state that rules, it's that of the foreign state. So in some cases, you may even have to go back out to that foreign state to sit in front of a judge, depending on what happened in an accident. Similarly, with telehealth, the law follows the patient, so you need to be licensed where the patient is at the time of the contact. Many people think that you have to be licensed where the patient resides, but that's not true. You have to be licensed where the patient is at the time of the contact. So if the patient goes to Hawaii for a week, then you have to be licensed in Hawaii, technically, to offer them telehealth services. You need to be licensed where they are. You really need to go to your board and find out what they want. And I strongly recommend that you get that in writing. You don't just call the board and ask them. So get it in writing. Typically, email is the best way to write a board, and then you'll have a timestamp and a date stamp. Some states allow you to be licensed under a registration for 30 days or 60 days or 90 days. Some states that registration is valid a certain number of miles over state lines. In many different types of either state emergencies or national emergencies, there are affidavits that are available to easily go into a state. So these affidavits are something to look out for during especially the national emergencies, because they could give you the authority to practice over state lines. There are a number of groups that have come up with model acts. Some of them have to do with shared licensure, such as the PsyPact for psychologists. Others have to do with shared documentation. And one of those is the Federation of State Medical Boards. I encourage you to see what's available for your particular profession, particularly in the last few years. Since the beginning of COVID, things are changing rapidly. When there's an interprofessional team of professionals that work with shared patient populations, supervisor might very well make the faulty assumption that everybody else has to follow licensing rules, but that's not true. Every professional is responsible to their own licensing board. It's best for you to check with your own board, and if you're supervising anybody else, or if they're working under your license in any way, have them check with their boards and get that in writing before you make any assumptions. So we'll move on to remote therapeutic monitoring, because this is the fastest growing area. We're seeing an increased amount of reimbursement for it. So of course, clinicians are focusing more and more on it, and technology companies are growing, offering different types of remote patient monitoring or remote therapeutic monitoring. The first term, remote patient monitoring, is largely focused on medical measures. So you might be taking vitals, for example. Remote therapeutic monitoring has to do, in most cases, with behavioral measures. Simple version of that might be an activity tracker or an attitude assessment. A medical could be a checklist of COPD symptoms. They help with not only letting the clinician know what's going on, but they are motivational for the patient in many cases. It can be an esteem booster. It can help people foster more of a sense of independence, that yes, they can operate on their own. And the CPT codes involved with remote patient monitoring can include having your staff look at reports rather than you directly looking at reports. And there are a number of other activities that can increase revenue related to telehealth. There is a facility fee that Medicare has paid for a long time for telehealth, but they have their rules. The fee can be charged to Medicare by the facility only, not the clinician. So it cannot be charged by remote staff, for example, your staff that is at home or in another office, a clinic, or a hospital. It has to be charged by the medical office, the clinic, or the hospital itself. So the patient in this model would go to the facility where the facility fee can be claimed. The amount has been decreasing every year, but it does tend to stay in that $20 to $30 range. The patient's responsible for unmet deductibles. On average, it's about $20 a session. It's designed to support telehealth program adoption and maintenance. Many telehealth companies were able to sustain themselves in the early years of their development with this fee alone. We'll focus a little bit about audio-only telehealth next, because much of the COVID research is showing that a remarkable number of sessions were offered by telephone only, audio only. When you offer services by telephone, ask about privacy. Who else might be hearing them speak, and do they want those other people to hear? They may not have realized it, but they could be compromising their own privacy. Do they have the language barriers? If you've worked with people in immigrant populations, for example, you might know their English as a foreign language is a big issue. They may not be able to fully express themselves because they just don't have the vocabulary. Are there articulation barriers? Do you have trouble hearing them? These are the kinds of things that you really can use to rule out whether they're appropriate for telehealth. Not everybody is appropriate for telehealth. They may not be able to get into a private environment. Maybe they are present with people who are signaling them to respond in a way that isn't true, and they give you a false answer in which you base your decisions. So it's important to always ask about these things. Telehealth interpreters are available in pretty much every language that is spoken in the country. Many of them are available by phone, of course, but there are a remarkable number of them that are available to come on camera with you. And these interpreters are trained in healthcare. They understand concepts, they understand language, they understand the acronyms you might use, and they can interpret what you're saying to the patient. Of course, this does slow down the session because you have to wait for the interpretation to go back and forth. There are laws in the United States that require you to speak in the language that the patient prefers. And that's why this whole industry of telehealth interpreters has come about. When you're working on the phone in particular, listen for silences. There might be things going on there that you want to ask about. Rather than just remaining silent on your side, you can say things like, what's going on? Are you having trouble thinking of what to say? You can cue people, open doors for them to answer yes or no. Listen for hesitancies. Are they stuttering? Are they tripping over their words? Is this an unusual process for this person? Avoid multitasking. It's particularly well documented that professionals working through the telephone tend to multitask. They might be opening their email, they might be checking their text messaging, they might be doing all kinds of things, trying to eat lunch, grab a bite in between statements. But if you stop and think about the fact that now you don't have someone's presence in front of you, you don't have that physical sense of them in the room, you don't have the visuals with them, you're limited to their voice, and you're diminishing that by taking your focus away. So owe it to your patient to pay full attention to them. The beeps, the rings, the typing, these are the things that patients report while they're on the phone with you. Speak slowly, take the time to make sure that you are articulating. As far as video goes, there are a number of best practices. We won't have the time to go through them all today. I'll hit some of the high points for you, but you may want to ask a team leader to be your office point person, to be your champion, who will make this happen. They will tend to the details, will do it with energy, will do it with excitement, and that excitement will spread to the other people in your practice. You can offer special status, pay them for their time to get formal training. You might have them develop protocols for your practice because they would know your practice and what the contingencies are. So you can have them come up with things like emergency response protocols, what exactly needs to happen, who exactly is going to be in charge of what, and have all that written out. Part of video telehealth in particular is to come up with these written protocols, the informed consent documents, the policies, and having that shared with everybody on staff. And then, of course, you want your security team to provide up-to-date reports to this point person. You would want your office champion to know what's going on with security. What does the rest of the staff need to know? What are the things that are going on this month? Let's shift to record keeping. One of the things that you'll want in your telehealth records is the modality used with each patient. So when you open your patient record, then you just write telephone, video, any significant interruptions, any equipment malfunctions, who was present, was the patient, were interpreters involved, what worked and what didn't work about the technology. This is very important to put in a record because somebody may come along 6 months from now and want to try telehealth with somebody that you determined was not appropriate for telehealth. If they don't have the right technology, if they cannot find a private place to speak, if there are too many interruptions or screaming children, people banging on the door, there are people that live in environments that are just not conducive to telehealth. You'll want to note that there was a consent for telehealth in particular. Many states have rules about this. You absolutely need to write in your patient record that they agreed to telehealth. If you have somebody sign an informed consent document and email that to you, that's telehealth. Regarding consent, ask any questions that they might have about the process and document that. In a court of law, the questions that you answered about telehealth will go a long way to proving that you did have an informed consent process about telehealth. What's going to happen, what's not going to happen, when you'll be available, what you expect of them, their geographic location. Once again, you want to document where they are, and they need to be told in the informed consent document that they need to be in whatever state you're licensed. Your privacy concerns need to be voiced in your consent document. They are to be in an environment where other people can't hear them. If there's a door in the room, that the door should be closed, minimize interruptions, and whether or not you want them to be recording. Most informed consent documents talk about the fact that you won't be recording it, and you expect they won't be recording it, and that you expect that they will tell you if they decide to record anything. Those types of legal clauses in your consent process can go a long way to protecting you. Some articles have been published recently to help practices know if they're being successful. So the first step, of course, is to identify your goals and evaluate whether you're meeting your goals. Think about whether or not this makes sense for you. Decrease wait times for visits, decrease absenteeism from school and work, decrease clinic no-show rates, and to decrease risks and barriers associated with transporting medically complex patients to the hospital, increase satisfaction while offering alternative care models. Metrics: virtual visit volume, the number of visits that they had, the number of physicians and other health professionals that were trained and actually using the services, the number of additional appointments they were able to fit in to their week, patient satisfaction scores, professional satisfaction with the virtual visits, the no-show rates, absenteeism for the patients, improved use of the clinic space, the actual brick and mortar building, and the associated resources. And that includes support staff, the technology staff. Are you able to maintain the same level of care using technology as you would if delivering care in person? Telehealth resource centers form a network throughout the United States that geographically segmented to have more localized information about the vendors that might be useful, about different state laws that might be changing, things that might be of local interest as opposed to something that's nationwide. One of those resource centers is called the Center for Connected Health Policy, and that is the policy center that feeds all the rest of the telehealth resource center network. They focus primarily on reimbursement and interjurisdictional practice policies. All of these resource centers, including the Center for Connected Health Policy, are federally funded to serve you 40 hours a week during business hours. So you can call them, you can write to them. Another large resource for telehealth is the Veterans Administration. They have competency-based protocols for many of the services. With Dr. Gebara, we talked about the Veterans Administration protocols for COPD. They have many other ones that you might find useful in your practice as well. Your reimbursement sources, particularly Medicare, there's a lot of information that can be useful for you with regard to telehealth. Of course, you'll find many journal publishers will give you information and make that available to you as open source information. I'm going to just give you some of the documentation produced by Medicare. They're free and they get updated every year. It's easy to find online. In conclusion, we've talked about how telehealth is a developing field. It's projected to become a $250 billion industry by 2031. It will become integrated into patient care, much as antibiotic medicine was integrated in the 1930s. Back then, there was a tremendous controversy about whether it was acceptable, and today it is part of the standard of care to be using antibiotics in many situations. Telehealth has the potential to transform healthcare delivery if properly managed by clinicians and improve patient outcomes and streamline clinician workload. Empathy skills are important, particularly in telehealth. With that, I'll leave you. I wish you all the best. It's been my pleasure to offer you this training. Let us know if you have any other questions.